Share screen. Okay, hopefully, yeah, I'll just bring that over here so I can see you. Is that still sharing the right thing? I hope. And then here.
Yeah, that's sharing.
Okay, good. All right. Oh, look, the video's working. Okay. Waving. Okay, so retinoblastoma, another globe tumour. So when I worked at the Children's Hospital at Westmead in Sydney, we saw quite a few of these, being a children's hospital. And this is what we're going to talk about today. Learning outcomes, understanding the why. Always start with why. Now, this is the important part for you, and it's also good exam questions. What information to communicate to your pathologist? You know, exam questions are like, what information should you write on the request form? How to send it? Another good exam question. Histopathology retinoblastoma. Well, if you get a case in the exam, you have to know that. TNM staging. Well, that's part of prognosis. Histologic high risk factors. That's part of prognosis and of treatment. Mimics and other pediatric orbit tumours. Right, why enucleate globes? You may have seen it before. Can we open up the chat window? And I want people to type in one reason why enucleate a globe when you think it might have retinoblastoma, because you can do laser, you can do radiotherapy and all sorts of things. So okay, I've got a couple of suggestions. I need a few more suggestions than that. Yep, if it's painful and blind, yeah. Other eye, extraocular extension, yes, structure compromised. It's those high stage ones generally. What, failure of medical therapy? Yeah, let's see, and I'm going to advance that. Because a lot of retinoblastomas these days are not enucleated. There's a declining trend of enucleation and an inclining trend of other things. But these are the reasons that a globe will get enucleated. Cure, no visual function. So people have mostly covered those, haven't they, Diane? If you monitor the chat for me.
Yep, I will.
Quite often they come at high stage because they come from the Pacific Islands. What about you, Diane? Your high stage RBs?
We don't get them anymore, unfortunately. They all go to Christchurch.
Oh, okay, they're diverted. Okay. Right, yes, declining trends. I did an audit and I can do another audit, and we'd only get a couple per year per population basis. That's all declining. Right, information to write on the pathology form for your pathologist. Of course, left or right. Now, the prior therapy is really important. Why is prior therapy important? Write in the chat, but don't press return. Everybody, write something. Why do I need to know? Before, on the request form when you send it, and the clinical stage. Why do I need to know? Okay, press return. Yep. Impacts the grade, affects the histology, changes the morphology. These are all good suggestions from those who put things in. Yeah, due to treatment or actual tumour. So if you don't tell me, I won't be able to distinguish the difference between some of those things, particularly if there's hardly any tumour left because you've lasered it and lasered it and lasered it. Clinical stage is important because it helps me know how to cut the tumour. Okay. Right, how to spin the specimen. This is how I like to get them, fresh and orientated. How about you, Diane? Well,
I like to get them like that too. You don't need to send melanomas fresh.
No, melanomas, formalin. Yeah. So this is special. Why are they special? Why do we need to receive it fresh? Type in the chat, don't press enter. Countdown, 3, 2, 1, return. Yes, because of genetic testing. I need to scoop out a fresh bit. And orientation is important because, well, I like to cut it in the correct direction. And once you send it, it's really not quite how it looks like in the radiology. Let's see. Harvesting fresh tissue from an
Harvesting fresh retinoblastoma from an enucleated globe. Ink the optic nerve margin before taking the section. You'll need a marker pen and sterile forceps. I find ripple foam is very useful for holding the globe steady to stop it rolling away. The superior calotte is indicated with a black marker and is incised with the tip of a scalpel blade. The superior calotte is further opened with scissors, leaving a hinge posteriorly. In this case, the tumour is anterior to the equator and is easily seen through the pupil. The tumour is harvested using sterile forceps and a new pipette. Place the tumour in a clean freezer tube.
Right, so that is what we do in the laboratory and why we need a fresh tissue sample. Right, video, we did the video. Here I've just, the blue stuff is ink for orientation and that's showing the cutting lines. Oh, calottes. What is a calotte? Okay, options are, what is a calotte? Tell me, write in the chat.
They're trousers worn by women.
Yes, sort of divided skirt thing. Yes.
Yes.
Yep. Anything else that they could be? Calotte. C-A-L-O-T-T-E. Okay, press enter. What have we got? There is a, it's a chapeau, correct. It's a little monk's, a French monk's skull cap. So where's the skull cap? There's the skull cap. So that's the calotte off one end, and then there's a calotte off the other side, and the bit in the middle is the pupil optic nerve section. Those are the terms that we use. So we only make two cuts. 1, 2. Calotte, calotte, pupil optic nerve section. And that explains why you're looking at the sections that you do look at. French monk's skull cap. TNM staging. So all tumours have a TNM staging. This is different from melanoma. And stage S describes spread, which is involvement of structures and adjacent organs. But of note, the anterior chamber is not mentioned in the tumour node metastasis, which I think is rather odd, but we always mention this in the pathology report. Why do we need to mention or look at the anterior chamber in retinoblastoma? Type into the chat, but don't press return. Why anterior chamber? And press return. Go. Yes, because it is a poor prognostic indicator because of TNM spread. Yes, and stage, and yes, metastatic risk, all of those things. You are onto it. Let's have a look at different stages. So stage S for spread. This has nothing to do with grade or classification. It's a different pathology terms, stage, grade, classification. Don't get them mixed up. Big retinoblastoma, so retinoblastoma here, retinoblastoma here. This is the optic nerve. This is not quite pupil, but it is an optic nerve section. Optic nerve is penetrating through the sclera, through the lamina cribosa. It's all dark purple. It's the color of the retinoblastoma. This is the worst because it is at the margin. So what does that mean? It's in the patient. This is some of the troubles that I have when there has been a lot of prior therapy. So this had chemo, cryo, and laser. And it was very hard to see any tumor at all when I transilluminated it, but you can see the tumor here. It's here in the anterior chamber, which makes it very tricky for me. I need to know that beforehand because the only place I can harvest fresh tissue from is the anterior chamber. So I have to cut it so that the aqueous won't all fall out and I'll lose the tumor. I have to cut it and suck out from the anterior chamber. important to know. And where was it? Well, you can see here in the posterior cavity, the only place the retinoblastoma was where there were a few little cells stuck in between the processes of the ciliary body, and the rest was like lining the surface here of the anterior chamber. A very small amount was left. More examples of different stages. So here we got the white pupil reflex, and this one here is confined to the posterior cavity. This one here, different one, it's very red on the outside. It's got it's incited vascular congestion. And if we look into the cut section of the same globe, see this little fine dark line here? That dark line there, it is the, type into the chat, what's that dark line? I'll give you 3, 2, 1, enter. Yes, it is the RPE, retinal pigment epithelium. So it is something that I can see that indicates to me whether the retinoblastoma has invaded the choroid or not. So choroid will be outer to the RPE. So this has got choroidal invasion as well as going into the posterior cavity. The poor old lens has been dislocated over there. So I can tell stage, and that's a big one, more than 3 millimeters, just by the macroscopic description. Typically, you might be able to see that on your radiology as well. What can we see here? Okay, does this have choroidal invasion or not? Type into the chat, yes, choroidal, or no, choroidal. 3, 2, 1, enter. Yeah, that bit, right? And of course, the clue is here. There's your RPE, and this is in choroidal invasion. So that makes it a higher stage. And of course, in the choroid, it's full of blood vessels. Different stages. What have we got here? This looks here, some choroidal invasion up here. Not quite through the optic nerve, but that's also where I would be looking. This one here, anterior and chamber invasion. It's cloudy down here. And this is suspicious for massive choroidal invasion. Actually, not even suspicious, it really is. So, and what's the definition of massive? Well, it's the eye, so anything small is massive. 3 millimeters is massive. So I didn't make the words, but the massive choroidal invasion is part of our staging system. So that's got massive choroidal invasion. And here it is. So this is in the retina, but that little sliver down here, that's more than 3 millimeters, and it's in the choroid. So it's a high stage. But look, see how it's invaded, it's involved the iris and the ciliary body as well. And look how it's crept along the retina and crept along the retina here. Maybe the anterior part, pre-laminar, but it has not invaded into the optic nerve. So that's good, and it's not at the margin. Histology structured reports. So these are some of the things that you have to mention if you get this in at your exam. Tumor type. Well, okay, it's a retinoblastoma. Optic nerve. So these are your options.
How do we tell the difference between differentiated or undifferentiated?
I don't actually bother. Do you?
No.
No, I might take that out. We'll just
Okay.
put tumor type. Yeah,
Yep.
too much information. So, differentiated, I think, is meant to have more Flexner, Wintersteiner, and Homerite rosettes. Yeah, does it matter?
If
No.
there's no rosettes, then it's undifferentiated.
Yeah, if there's rosettes, it's differentiated. It doesn't make a prognostic difference. I don't actually put it in anymore. Optic nerve. This is important. No, pre-laminar. Laminar refers to lamina cribosa, which is a sieve. It's a sieve where the nerve fibers exit the sclera and turn into the optic nerve. Laminar at the level of the sclera, post-laminar, posterior to the sclera and the margin, self-explanatory. Scleral invasion, it's binary. Extrascleral invasion, binary. Massive choroidal invasion, you've had a lot of that. And anterior segment, absent or present. And these things here, for the reasons that you already mentioned. Okay, histologic risk factors for progression post-enucleation. You should be able to rattle these off because these are important for, you know, exam questions. Exam question. List the histologic risk factors for prognosis post-enucleation of a retinoblastoma. Right. At least 3 things. Okay, 1, 2, 3. You've seen a picture. Post-laminar, I showed you a picture of that. Anterior segment, I showed you a picture of that. So now you have image pictures as well as word pictures in your head.
I love making mnemonics. I love so map.
Oh
Yeah.
yes, let's go back. Let's make a, oops, oh, hang on. Hang on. Will I go backwards? Hang on, page up, page down. The trouble when you present off the internet. Okay, yes.
Map.
MAP, M-A-P,
Mm.
massive choroidal posterior laminar anterior segment, MAP. Retinoblastoma mimics. Oh, I should. Okay, you've had a little look at that. Now let's just do an immediate recall. Type at least one of histologic mimic into the chat. 3, 2, 1, enter. Yep, so Coates. Retinocytoma is a bit tricky. They're quite rare. So Coates, Toxo, PHV, those are the usual ones. We don't enucleate for Coates though, do we? So you're unlikely to get a specimen of one of those. What's next up? Are they clinical or histologic mimics? What should we say, Diane? Well, are we fooled by any of these?
No, we're not fooled by any of those.
None. They're clinical mimics. We don't
Yeah.
have any trouble determining the difference, none whatsoever. You could tell at low power what they
I've
are.
just written medulloepithelioma. That might trick us
Yeah.
sometimes. That's a small
Yeah.
round blue cell tumor.
That's a histologic tumor. Yeah. Fuchs
And-
adenoma.
So probably the wrong age group, and they're usually very small. So
Yeah. And discrete sort of thing. Yeah.
should we list them as a differential in the exam after we've seen the histology? No.
No.
Histology will be entirely obvious and full of small round blue cell tumors.
There would be no differential diagnosis, because if you just list these, then we can tell that you actually don't know what you're talking about because you're unable to identify things and you're just repeating things from the textbook without applying the knowledge that you should have learnt. So, like, no practical skills, just book skills. Right, Coates. We did get one at Children's Hospital at Westmead, and it looks quite different. It's full of this glassy exudative substance, and the poor retina has fallen off here. There's no tumour, absolutely no tumour whatsoever, but it does have a white pupil. Pediatric orbital tumours. So these are not retinoblastomas and they're not in the globe, but since we're talking about pediatric tumours, there's probably 2 that you should be aware of at least. Type into the chat a malignant pediatric orbital tumour, 1 or 2. Type them in. 3, 2, 1, return. Rhabdo, yes, and a metastatic neuroblastoma. Okay, good.
Good.
Rhabdos are good. Excellent. So let's have a look at these are typical cases. 6-year-old, 2-year-old, massive orbital mass. Notice there's nothing wrong with the globe. Globe is an innocent bystander. I mean, does this look like a retinoblastoma? No, it does not. Rhabdo, metastatic neuroblastoma, and everybody typed in malignant things. Tumours can be benign or malignant. Tumour just means space occupying mass, doesn't it? Mass, tumour. Infantile hemangioma. So that is a tumour. When I was in Singapore, I had an enucleated mass from the orbit, not the whole globe, because there's nothing wrong with the globe. They sent it as a rhabdomyosarcoma, came from Indonesia. They really didn't have much to work it up. It was an infantile hemangioma, a benign thing. So it really didn't need to be excised. What's the treatment for infantile hemangioma in the orbit these days? Type into the chat. 3, 2, 1. Yes, drugs, propranolol. So these are pediatric orbit tumours that you should be able to list. Rhabdomyosarcomas. Well, they fall into a morphologic class called small round blue cell tumour, and that's exactly what it says on the label. The cells are small and round and blue.
If you've mentioned that you want to receive retinoblastomas fresh, do you want to receive your orbital masses fresh?
In my current institution, there is no need. We would look for, so the reason that may become a question is because we want to look for translocations to subcategorize rhabdomyosarcomas, because there's two types. And one sort has a translocation and the other one doesn't, and they have different prognostic indices. Type into the chat, everyone, what are the two types of rhabdomyosarcoma that occur in the pediatric age groups? You can just use the abbreviation. 3, 2, 1, enter. Matt is a fast typer. What about everyone else? Yeah, so there's embryonal and alveolar type. And how to remember them? Alveolar is like, I think, adolescent. They occur in the slightly older children, and A equals awful. So they have the worst prognosis. They occurred in adolescence, and they also have a translocation. And can you tell them apart on histology? The answer is sometimes, but we always do a translocation marker. So here's an embryonal rhabdomyosarcoma, and these are primitive rhabdomyoblasts. They look like tadpoles, and see that eosinophilic cytoplasm? That's the muscle cytoplasmic elements in a primitive form. And alveolar rhabdomyosarcoma, alveolar means, in the olden days, they thought it looked a bit like lung alveoli because they're falling apart in the center. It's got nothing to do with lungs, and it's just the morphologic pattern. But we would always do a translocation study. It's got a Fox translocation. Oh,
Would you fish it, Amanda?
Yes, we fish them. How do you do them? I've just gone blank. Why is that? I don't know. Anyway, I've come up to the end. I don't know where it's gone. So,
Or it's not either.
please wait. Okay, I will stop sharing, and
We'll look at the eye, shall we?
we'll look at the eye, and those are the prognostic factors that you want to. What classes of genetic tests do you need the fresh tissue for retinoblastoma? What classes of genetic tests? We're looking at.
Just trying to understand how it's different to the melanoma, because in melanoma you're also doing genetic tests like
Yes.
So why is it different in retinoblastoma?
We're looking for germline mutations, and it can be particular to the individual or the family.
For
blood test?
So for melanoma, we're doing FISH because we're looking at big changes, big changes. But for retinoblastoma, we use next generation sequencing, which is much easier to do on fresh tissue because we're looking for point mutations within the RB gene.
Okay.
And formalin fixed tissue kind of like mucks it all up, and it's much harder to do next generation sequencing on. And what we do is we sequence in the tumor the gene and find the point mutation. And then what we do is we look in the blood so that see if the same point mutation is there. And then we know it's constitutional. And then we look in the family. Now, each family will have a different point mutation. So we'll need to sequence the gene for each case to check each individual family.
Oh, here's a question, Diane. Can you tell from the histology, just the histology by itself, if it is familial or acquired?
No, that was easy. No, we can't.
Any other retinoblastoma questions before we get in there? Or pediatric ophthalmic tumor questions?
So the right answer for the exam is no differential diagnosis.
For retinoblastoma.
There is no histopathological differential diagnosis.
And do we look for the PAX translocation? Yes.
Yeah,
And
because
the
we can see translocations with fish because it's
Yes.
two different markers just being brought together or broken apart.
Yep.
Do we routinely look for MYC? Yes, we do.
Yes.
And again, that's done with fish because we can count the number of MYCs by the little glowy points.
Yep.
But it's most important in neuroblastoma.
Yeah. So we talked about the primary pediatric ocular tumors, and the most common metastatic tumor to the pediatric orbit is, just give me the abbreviation, type in 3, 2, 1, enter. Yes, a neuroblastoma. So what is it? Your blueberry muffin baby with the big raccoon eyes. And we do a MYC workup for that one as well. So you're thinking all tumors, is it benign or malignant? If it's malignant, is it primary or secondary? It's a good framework to think about everything.
Okay, we're going to look at the next eye, sorry. This is a Path Presenter. When you click on the link, it will prompt you to log in. Now, I asked you all, remember, to join Path Presenter on the initial email. So once you're in your groups, find the person who's actually managed to join Path Presenter, and they will be the driver. You've got a different tutor this time. I checked the link.
Oh, so does that mean we're all in a group together?
Yep. So
Okay.
Matt, you didn't appear on my thing. Did you get an invitation? You are in group. Oh, you're unassigned. I'm going to put you in group 2.
Okay.
And Chris, you're also unassigned. I'm going to put you in room 4 with me. No, I'm not. I'm going to put you in room 3 with Charlotte. And Michael, are you okay there? Okay, welcome back, everybody. How was that? Do we have any questions in the chat for that one?
Oh, good. Yeah, type them in now and then we can address them when we go through it.
Would you like to share screen, Amanda? this time?
Yes, I will. It's just loading my Path Presenter at the moment. Oh,
So just to
Right.
recap it, it is just fish and next-gen sequencing for RB once you've got the specimen.
It's just next
yeah, we don't do fish.
Oh, sorry.
because we
Okay.
don't, because we
Confuse myself.
don't count MIC.
Right.
Some places might. Yeah.
Okay, just
Right.
next-gen.
So,
Thank
so Sarah says, can you please explain endo versus exophytic, Amanda?
Sure. So endo, we will, hang on, my picture's just coming up best with a visual aid, right? Hang on, share screen, where's my share screen thing? Share screen, oops.
Are we
share
expected to
screen.
stage the tumour? The answer is no, we don't expect you to memorise staging systems.
No,
What we expect you to do is to comment on the things that will influence stage. So
you should name the structures.
name
know.
the spread. Where is it spread to?
Or hasn't spread to.
Or hasn't spread
Okay.
to.
If you didn't mention the optic nerve, you'd miss out on all those marks.
Yeah.
Yeah.
So endophytic versus exophytic.
Right, endo means towards the center, right? So, and the dividing line is the, oh, I'm driving, therefore I'm zip. So Diane is talking.
All right, so
Yes.
endophytic means towards the center. So in this tumor, there are areas where it's growing in towards the center, out of the retina and bursting out, or, sorry, I should, is the tumor mainly underneath the retina and growing out, or outside the retina and growing into the vitreous? Let's go, we're going to put under or over the retina in the chat. Is it under the retina or over the retina?
Oh, maybe we should use under and over as a bit gravity specific. To the inner or outer? How about that? Inner or outer? Endo is inner. Yep, that's my understanding. So exophytic is risk for choroidal invasion.
That's
Endophytic, who cares? Doesn't
so
matter.
this one is mainly exophytic because the retina is predominantly intact over the top of it, and it is growing. There's a little bit of choroidal invasion, which
you identified? Okay.
Yeah.
Okay.
And it doesn't break through the retina and grow into the middle. That was my understanding of endo versus.
Yeah. Does it matter? Is it prognostically significant? No, it doesn't matter. I don't even mention it. I only talk about things that matter.
Could you show us where the choroidal invasion is? Because our group were kind of debating.
All right, and we want, so if we could go a bit superior, a bit towards the optic nerve, Amanda, and then beyond the optic nerve.
Up here?
Yeah, just there, just there.
There, okay.
Around there, yeah.
Just going in.
Right, so the way to spot it is to track along the
RPE. Yep.
So keep going a bit further.
Yeah. Oh, there's a little bit there.
That's the little bit, right? So it's just popped onto the RPE.
Teeny weeny bit. Okay. Ooh, that's quite tricky, isn't it? Yeah, so I'm following the line.
Yeah, but I just follow the line around and see it.
So mainly this is an endophytic one with that teeny bit of exophytic. So endophytic, well, we don't care how big it is. Is there a size thing? Is there a size thing with retinoblastomas? Do we have to worry about the size?
I don't think so.
No, we don't.
Involved.
No, the size makes no difference to prognosis, but the size of choroidal invasion does. So this is not massive because it's less than 3 millimeters. More questions?
For exophytic, it's got to invade the choroid.
exo is coming out, choroidal invasion here.
Yeah.
Yes. How to identify the lamina cribosa? All right, let's talk about that. Diane, how do you identify the lamina cribosa?
So the first thing, my first guide at low power is the bit where it becomes very, very narrow. So yes, the level of the sclera is where it starts.
Yep. And where does it finish?
It finishes at the other end.
Other end of the sclera. So you just draw a line from the sclera to the sclera, and that's the whole lamina cribosa in between them, basically. So, yeah. But so we have to identify, is there invasion of the optic nerve? And we were allowed those choices. None, pre-laminar, laminar, post-laminar margin. So what's happening here?
No, I think that's going between the columns of the optic nerve. I think there is laminar invasion here.
Yeah. So pre-laminar, we draw the line like that. So the optic nerve fibers are coming out onto the, out here. Pre-laminar? Probably.
I think it's pre-laminar invasion.
Pre-laminar invasion. Draw our line here.
We had a bit of a discussion about florets and Flexner Wintersteiners and home lights. So these don't matter to the prognosis of the tumor.
They don't really matter at all.
But there's lots and lots of Flexner Wintersteiner rosettes here with little florets in them.
Yes, florets. Do you mention the different types of rosettes in your reports, Diane?
So sometimes I like to sound clever and do, but mostly, I mean, it doesn't matter.
I don't even mention them anymore. The reason that I like to identify them is that it confirms to me it's a retinoblastoma. That's it. Do you do any special stains? Do we need to do a special stain for this?
I don't do any special stains. Do you do any special stains? How
no
about
need.
Bridget, do you do any special stains?
No, we don't.
No, so we all just do H&E stains.
Because if it's, you know, comes out of a 6 to 2 year old child, it's only one diagnosis. And, no need for special stains.
I do levels again though, particularly leveling through the optic nerve. If it's looking like this in particular, I want to look very closely right through the whole section to see whether it is in fact going to go into the lamina fibrosa.
Yep. Or post-laminar, if it's post-laminar radiotherapy, right?
Yeah.
Okay, good.
Excellent. So
no other questions there? Don't think so. There, I'm just checking. All good. So pretty obvious. And I think in the exam you would get the age of the patient. Yes.
All right, so we're going to now have a look at the next slide.
Charlotte's had to go, so we're one tutor down.
Okay, all right. So how are we going to do this?
I can jump between 2 rooms if you like. You can put me in a room with 2 people and then a room with 2 other people, and I can spend half the time in the first room and then the second half of the time in the second room.
Okay, so I will move you to 3. So everyone, can you please open the next slide as we go there? Yep. So I'll put you in room 3 and room 4.
Okay, and I'll just go between those 2 rooms, 3 and 4. So I'll go in room 3 first and then in room 4. So,
right. And I'm just going to move some people around so that everyone gets to new tutor again. And yeah. Okay, and I'm in room 5 this time. All right, so Amanda's in room 3 and 4. I'm in room 5. Bridget's in room 2, and Sarah, you're in room 1.
Okay.
And there's one person unassigned. Who's unassigned? Simone. You're unassigned.
Sorry, my Zoom fell
So
apart and logged me out.
you can go into room 5 with me.
Hmm.
Whereabouts in Queensland are you, Sarah?
At the Royal Brisbane at this stage.
Very good.
Steep learning curve. It's quite tricky, I have to say.
Yeah.
There's just a few colors and gotta really look into them individually. How do you do it every day under the microscope? I can imagine. It's like, cells.
Great. That was a bit of a quick one because it was just one thing to see. Okay, I'll share my screen.
Okay, we're back. I had a technical problem. I couldn't get into room 4. I think I need to be a host or something to jump from room to room.
Sorry, room 4. We'll give you a rundown.
That's all right. We had a nice chat, me and Margaret.
I think
you can ask all the questions.
Right, I will do that. So yeah, so here we go. This is.
Oh, it's a lovely case. I can't remember. I think I might have put it into the QAP. So.
My mouse is very sensitive. I tend to zoom in and out a lot. All right. So one of the
questions.
One of the things my group struggled with a bit was identifying. I mean, clearly it's got lots of vessels in it. So it was about like, was this a small round blue cell tumor, or whether it was like not a small round blue cell tumor. And so I talked about the overall impression being pink.
It's pink.
Pink. There's quite a lot of space between the nuclei. They aren't like hugging each other, definitely. And also, were all these cells endothelial cells? And the answer was most of them are, because even this bit here is starting to develop a little lumen.
They're sort of primitive, sort of more cuboidal rather than like a really flat endothelial cell, because you have to be well differentiated to be flat. So I think these are a little more, well, everything come, infantile. So what say we make a clinical scenario? So this child was born with apoptosis, and the radiology showed a solid lesion with some blood flow, but not much. And it was still there at the age of 6 months. So there we go.
Yeah.
And that's our clinical scenario. I've just made that one up. There's not many things that can look like that. So
we went through the thing. Do you think there's any normal tissue there?
Yes, around the outside I did, on the bit that's pointing down like a little teardrop. We saw some fat. So adipose tissue, which doesn't really catch your eye because it's so low density, but they're fat cells.
Like
We can
here?
find some fat cells. Yeah. So if it's from the ophthalmic region, well, it's probably from the orbit.
Yeah.
So,
Fat
I mean,
cells.
could be subcutaneous, I suppose, but orbit most likely.
So
That's normal fat.
I think everyone found the key features, varying size of blood vessels going down to the very, very, very tiny. But talking about prognostic features, so because we can't discuss where it spreads to because it's
benign.
Benign.
Can they be multiple? Here's a question.
Could this be part of a syndrome?
I
don't think so. Oh, do you? Do you think it's part of a syndrome? Is it part of
So I would call this an infantile hemangioma.
Yeah.
So because in this age group, say if we're told it's 6 months old, it's the only thing it can be. I don't call them capillary hemangiomas because capillary hemangiomas occur across all age ranges and they don't respond to propranolol. But if I have the right history, I would call this an infantile hemangioma and I would expect it to have responded to propranolol. Although clearly this one didn't because either it wasn't recognized by radiology or it didn't respond to propranolol. That's why it's out.
Okay. So in answering this question, we would say that the normal tissue was the normal fat, that key features are varying sized blood vessels with moderate degree of cytoplasm, including numerous tiny blood vessels, and probably in terms of prognosis, I would say no mitoses, atypia. This.
And look at the circumscribed margin. Yes. Is it got infiltrating like cancer the crab?
Yeah, no infiltration.
No.
And also completely excised.
Yeah. Cure. Done.
All right. So what
can I also just mention, sorry, like with this case, if we didn't have a good clinical history or where this came from, we would not be able to tell. So can I just stress here the importance of clinical information provided to the pathologist?
Yeah, when it first appeared and what treatment the patient has had and what the response was. So that's important for classification.
And the site.
Yes.
And the site.
Absolutely.
Yeah. Would we do any stains on this, Bridget or Amanda?
Yes, I would.
What would you do, Amanda?
I would do a GLUT1, but I think that's probably not required knowledge for our audience here today.
So we can tell what kind of hemangiomas these are by doing some special stains, but we think just identifying them as hemangiomas will be good enough.
What say the participant said it was a capillary hemangioma? Would we give them marks for that?
So we would probably not fail them because they'd identified hemangioma, but we wouldn't give them high marks. In fact, I think we might move on to the next case just now.
For compare and contrast. Good.
Yeah.
Oh, and can I be something that can jump between rooms?
How would you can you tell histologically without a stain if it's a lymphangioma? Is it just because there's red blood cells in the lumen?
Lymphangioma doesn't tend to be so dense. This one has quite solid areas in it. Lymphangiomas have more space and less tissue. So morphologically, typically, yes.
Okay.
All right, so you're now a co-host, Amanda.
Oh, okay. Hopefully I can jump between breakout rooms.
I'll put you straight into room 4.
Okay.
For a start. And then we'll look at the next lovely specimen. Okay, I think everyone has joined a room. That's good. Henry, are you having trouble? And Simone's right. Okay, another vascular lesion, but different.
Yes.
Hello, Amanda.
Hello, I have returned. I got lost in cyberspace for a little while, but found my way out again. It's scary in there.
Yeah. Okay, so my group had a couple of questions.
Yes, shall I? I'll
share.
drive and you can navigate to me. Hang on, where's the share screen thing gone? Hang on, it's right down the bottom. Share screen. I'll go to the other one. That screen, share. Okay, now I'm over here. Yay. All good.
Okay, so at low power, what I can see is a whole lot of blood-filled spaces lying within normal orbital fat.
Yep.
Yeah. And so the normal thing is the orbital fat, and the abnormal thing is the vascular spaces and the collagen between them.
What's the green stuff?
Ah, yes, that's the dye we put on the outside. We often do that to specimens to make sure we've kind of cut to the edge of them so that we can see. Yeah.
Margins. Okay.
Okay.
Fat,
so,
collagenous connective tissue, blood-filled space.
Large blood-filled spaces. So the blood in the blood-filled spaces looked normal. That was another normal tissue. Had normal white cells in it. And it's lined by flattened endothelial cells.
Yep, we saw those somewhere.
And I didn't see anything else. Like I just saw collagen around them. I don't think I saw smooth muscle around them.
Yeah, I don't think there's smooth muscle here either. I think these are fibroblasts.
Yeah.
And wavy collagen, wavy collagen, connective tissue.
And a few lymphocytes.
A few lymphocytes, a couple of small blood vessels, fibroceptor.
So I thought that this was a collection of capillaries, dilated cavernous capillaries. But the question me and my group had for you is,
aren't capillaries a bit smaller? These are really big.
I know. Can we tell that? Yes, that's true. They're dilated varixes, aren't they? Dilated vessels.
They're vascular spaces. Yeah, just keep general. Can't be wrong.
So how do we tell the difference here between a vascular malformation and a capillary hemangioma?
A cavernous hemangioma.
Sorry, cavernous hemangioma. Cavernous hemangioma. Yeah.
People, do we want to ask our learned audience, what do you do clinically to determine that? Type into the chat or tell us.
Well, ultrasound, right? They're hyperechoic.
Yeah.
Very low flow.
Flow. So flow, you can often tell about AVMs, high flow, low flow. Yeah, that's one way to tell the difference.
So we get that information, shouldn't we? Query AVM high flow, because we can't see the flow very well here.
We can't do function, we can only do structure. You have to share that information because often we can't see into your reporting systems for all that sort of stuff. So cavernous hemangioma or AV malformation. I think those would be my differential diagnosis of those things. Sometimes I might just write a report like that and then put it back to you, and you have to decide depending on the flow and things.
Yeah, but we can't definitely see any veins or arteries here. They're just dilated vessels.
Vascular spaces.
Dilated vascular spaces, yeah.
Because normally in a vessel that big, you should have good amount of smooth muscle around it, but these are really odd looking because look, sort of some thickening there, but on this side it's only got one cell thick. So it could be an AV malformation because they have various range of vessels of different sizes and shapes. So
another question we had, Amanda, are capillary hemangiomas usually more circumscribed? No, sorry, not capillary, cavernous hemangioma is usually more circumscribed than this.
I think that can be a clinical question with radiologic correlation. No, not necessarily. I mean, vascular things are hard to get around.
They are. So I think the differential diagnosis between vascular malformation and cavernous hemangioma, both of those would be considered a correct diagnosis.
Yep, and it would be clinical things that would tell the difference.
Yeah, and so prognostically, there's no evidence of any malignancy here. And this one, because it's spreading out so far, it's going to be very hard to get margins. So not even margins would offer prognosis.
It may be incompletely excised, and therefore you still have vascular, may still have AVM left in the patient. So, yeah, it looks like some organising thrombus.
It does look like organising thrombus. Okay, we're
Okay.
due for a break now.
We are. Okay, stop share. Let me have a look at the schedule. What are we up to?
We are up to, it's a good time to break. So
Break time.
Break time. So we're going to do orbital. We're not too far behind, actually.
No,
You're going to
that's
stop
good.
recording?
Oh, stop
yes.
recording.
Yes.
I will stop recording and
Come back